The older adults with ALL have done very poorly. They do not tolerate chemotherapy well. Their outcomes traditionally have been very poor. So the question is, how do we modify, how do we apply the current therapies that are approved for relapse disease to the frontline setting, particularly in the older adults? So there are some data that, for example, if you, the classic example is Philadelphia positive ALL, where we can achieve deep remissions in older patients by using light chemotherapy with a tyrosine kinase inhibitor, for example. So you don't need very high intensity chemotherapy, and the outcome of these patients have improved a lot with this type of regimen. By the same token, you can add drugs like blinatumomab or inotuzumab in the frontline setting. So these will be better tolerated by these patients, and then you can use a lighter chemotherapy regimen to achieve durable remissions. So that is still being explored. Regarding blinatumomab use in the elderly, blinatumomab, if you use it with active disease, your response, your complete remission rates are about 45%. But blinatumomab has a much higher response rates when you use it in an MRD setting. So one question that we always ask, and the trials are ongoing to address this, is whether you debulk the patients with something else first, maybe another therapy like inotuzumab, render them to a lower disease burden state, and then use blinatumomab, so you can probably get durable remissions. So that's an approach I think is very interesting to modulate chemotherapy intensity, bring some of these relapse disease agents to the frontline setting, and achieve longer survival in these patients.